Thank you, Rosie. So today's crash course is unlike the other crash courses in that the diseases that have been covered so far have been around for a millennia or more. This is a new disease. It's only been around for 5 years, so I'm here to talk to you about what we were doing about it in this very short space of time, relatively. If you think about people studying malaria or cancer, that's been around for 2, 3, 5, 10 million, however many million years. I also want to start by posing you all a question. Why are you here? Why did you come today? Is it because you want to get inside this fabulous building, hear a bit about some science, learn a bit, useful thing to do on a Wednesday morning? Or are you here because actually someone you know has long COVID that you don't really understand and you want to understand a bit more so you can help and support them? Or are you someone who's living with long COVID and feeling a bit lost and stuck and want to find out a bit more? Hopefully, over the course of this talk, whatever your motivation for coming, I'll address some of your answers and hopefully you'll go away understanding a bit more, feeling a bit more empowered about long COVID. So first, a bit about me. I'm an infectious diseases doctor. My CV is there. But essentially, we've been preparing for a pandemic for a long time. This is me back in 2015 in an Ebola simulation exercise. You can see that it's not a hospital. The background is some dodgy red curtains in some office building. But we were preparing and learning to put on our PPE, taking it on and off. I unfortunately couldn't go and help in the Ebola epidemic in West Africa because I was pregnant at the time, much to my gutting this and much to my husband's happiness that I wasn't headed off to Sierra Leone. I moved to the Crick in early 2020 to work in a different lab on a different project, but I was rapidly called back into UCLH, as all the clinical academics were, to help on the front line, and I spent 3 months essentially dressed like this, looking after critically ill patients. And since then, I've been a consultant in the UCLH Long COVID Clinic, so over the last 5 years. We're actually celebrating our 5-year anniversary of the clinic last month. So I'm going to talk about long COVID in 3 parts. First, we're going to talk a bit about what is long COVID, and then secondly, what are we doing about long COVID here at the Crick? And finally, I'm going to end with what does the future hold for people living with long COVID? And warning now, I expect to end on a note of optimism. There's a few things I'm not going to be able to talk about, partly due to the constraints of time. I'm not going to talk about overlap between ME/CFS and long COVID. I'm not going to talk about drug treatments for long COVID outside of clinical trials, although I know there are lots of them. I'm not going to talk about many individual scientific studies in depth because there's not time, but I am providing references for the studies that I am going to talk about. Okay, and as Rosie already mentioned, I can't talk about individual cases. So first of all, what is long COVID? I'm going to start by introducing you to William Osler, professor of medicine in Johns Hopkins, who was a very wise man and gave his name to lots of disease, including Osler's nodes, which you get in endocarditis. He's got several quotes, but this one really resonated with me and will resonate with you in the pandemic. Think back to any bit of the pandemic you like. Masks, viruses, social distancing, return to work, bubbles, any of those things. You may not want to think about them, but this quote will resonate. The greater the ignorance, the greater the dogmatism. The less you know, the more likely you are to stick to your entrenched position, particularly in a position of fear. And that's happened with long COVID. But beware any scientist, particularly in a new disease or who is dogmatic, who says it's definitely this or it's definitely that. There's a lot of uncertainty we don't know, and it's important to embrace that. So here are some myths about long COVID, which people really spout quite dogmatically with no evidence at all. You can only get long COVID after serious illness, i.e. being in hospital or critical care. Not true. Long COVID is a psychological or mental illness. This is very common, and it is definitely not true. What is true is that having a disease that is poorly recognized by the medical profession, with no known cause or treatment, and unknown duration that impacts your ability to live, work, earn, is going to make you feel anxious and depressed. There is no doubt about that. But that is a secondary effect. It is not a primary disease, but that's often what doctors will see and focus on and not think about the disease affecting the person behind it. Long COVID only happens to people with underlying health issues. That's definitely not true. And long COVID only lasts a couple of months. In the majority of people, yes, I can see some faces being pulled, as we're going to find out, lots of people have had long COVID for much longer than that. And the other thing is myth that long COVID is rare, it's gone away, COVID's gone away, we're not bothered about it anymore. Not true. So post-infectious syndromes have been around for a long time. Here's the 1918 flu pandemic, which killed a ridiculous number of people after the First World War. But what was slowly recognised that there were a subset of people who survived but had really significant sequelae. And actually, Oliver Sacks wrote a book about this, a disease called encephalitis lethargica, people who couldn't get up, couldn't work, couldn't function. And Oliver Sacks, his book Awakenings, which was made into an Oscar-winning movie, if you haven't watched it, it's worth a watch, with Robin Williams in it, and Robert De Niro as the patient, started to use experimental drugs to try and wake people up and see what happened. Ebola is now recognised, while it has got a horrible mortality rate, those who survive, a significant proportion of them suffer from sequelae. SARS-CoV-1, interestingly, caused a really nasty epidemic in China in 2001 that went to Canada. And in a 12-year long-term follow-up study, a significant number of survivors were reported to have psychological issues. This is a Chinese study in Chinese authors, and it's unclear what those psychological issues are. Was that actually long COVID? Epstein-Barr virus has been linked over a long time with as a driver of ME/CFS, though there's very little definitive evidence to prove that. There's lots of causal association data. And let's not forget the bacteria. There are lots of people who suffer from sequelae after having Lyme disease. So long COVID is a patient-defined disease. The medical profession was not really ready to think about it, understand about it, listen. And it was patients that started to define the symptoms. And there's still a very vague clinical definition of long COVID. Persistent new onset symptoms. What does that mean? For more than 12 weeks. Following a COVID infection. Well, where does the 12 weeks come from? This is a really interesting study published earlier this year. And it's looking at social media mentions of the words long COVID. And if you look at the timeline, I'm sorry it hasn't come out terribly clearly. It starts in January 2020 and runs through to the end of 2020. And what you see is that COVID turned up in England in March 2020. We all remember that. And here's July 2020. And look at the peaks exactly 3 months afterwards. People start talking about long COVID and recognizing that actually they've had persistent symptoms since March. This range of symptoms are vast that people report with long COVID. This is a word cloud, and I was playing with different ways to try and describe the range of symptoms that we hear patients talking about. And I can show you various rather boring bar graphs. I thought this word cloud was a much cleverer way of doing it, because some of the really common symptoms, fatigue, cough, shortness of breath, breathlessness, muscle ache, muscle pain, and ongoing symptoms are the most common. But actually, there's a huge range of symptoms. So what does this really feel like to have long COVID if you haven't had it? Well, I invited Mag, who's unfortunately not able to be here today, but this is a video of her talking. She's one of our patient experts, and as this is a patient-defined disease, I've invited her to come and talk, first of all, about what she was like before and after living with long COVID.
Hi, my name is Mag, and I have had COVID since July 2020, so I'm approaching my 5-year mark now, and I'm still longing. Before and after is what I want to kind of bring your attention to, first of all. So before I was working in tech, I was a leader of a team. I was responsible for coding and leading and solving problems. I was really active before. I would have considered myself quite athletic, always moving. I love seeing people and I love seeing dogs and trees and stuff. And now my brain has to work at a slower level. There's a lot of forgetfulness. There's a lot of not being able to concentrate, forgetting things that someone has just asked me. So that's been a lot taken away from me. I can't do it. I can't do cardiovascular exercise. It puts me into a mess of pain and destruction. I've just had all that identity taken away. So it's a much deeper thing, as well as the physical things we have to go through and the pain and the suffering.
Okay, so she's given you hopefully a good insight into what's happening to her now and what happened before. And then I asked her to talk a bit more about the wider impact on her colleagues and what she'd heard from other groups about impact of long COVID.
There's a lot of identity narratives that we have to deal with. You know, I am no longer one of my peers on Stimulate ICP has had to have retirement at 36. She can't work as a nurse anymore. We were all out there clapping on whatever day it was for all the frontline staff. And, you know, I see her just going through trying to raise 2 boys at home, and her husband has long COVID that she brought into the family. You know, it's really heartbreaking. Another one of the team used to be a pilot. He, you know, very alpha type, and, you know, just thought, is it even worth it anymore? I might have long COVID forever. And there will be very dark times with it because it's very erratic. It's up and down. And today you see me and you're like, she looks healthy and vibrant and she's, remembering her words and seems quite confident. You don't see me at home when I'm crying to my girlfriend, and I just find the struggle so hard.
So how many people have got long COVID? This is a nice study from Scotland, and this is an infographic from that paper that really helps bust some of those myths. So one of the problems with recording long COVID data is that our clinical coding systems are really bad at capturing it. So in this study, they looked at 4.6 million medical records overall across Scotland. And actually the best way to pick out who the long COVID patients was not from the medical records. The coding was actually the smallest number. But overall, there were far more people out there than had been coded that we can pick up through when we look through NHS or NHS Spine. Which people had long COVID? Well, they found that women were overrepresented. People aged between 38 and 47 were overrepresented. And people who had been advised to shield at the start of the pandemic, they found interestingly were overrepresented. And that probably is partly due to immunocompromise. People who had one or more pre-existing health condition were overrepresented, and again, those who were immunocompromised. And finally, people who were living with obesity or being overweight were overrepresented in that group in Scotland. And these are actually very representative of data that have come out from the US, come out from the UK, Europe, and higher income settings. We don't have data on long COVID from lower income settings, unfortunately. This is another paper from Tess Greenhalgh and colleagues. It was published in The Lancet last year and essentially shows the same thing. This is looking at health records across the whole of the UK. And you can see again that age peak that we see, the overrepresentation of women, the same as in Scotland. And again, the overrepresentation, interestingly, of people at the time of being surveyed who were unable to work or not actively looking for work. And that's because they're living with long COVID. So I hear this a lot. Has long COVID gone away? COVID's gone away, hasn't it? Well, actually, COVID hasn't gone away, but we're all now much more immune to COVID, so less of us are getting sick. But there are currently 90 NHS post-COVID clinics across the UK. At UCLH, we're still seeing 50 to 70 new referrals a month. And in February, March last year, the Office for National Statistics estimated that 3.3% of UK adults are still experiencing symptoms 4 weeks after having had a COVID infection. So no, it hasn't gone away. We're still seeing it. And this is an interesting paper from the US and a large healthcare cohort. And on the side, we're looking at the percentage of people who have reported, who've had a COVID infection. And in the red dots are the people who say PASCAL, American word for long COVID. So what I want to draw your attention to is along the bottom, these are different factors that associate with the numbers of people who are having long COVID versus not long COVID with single or multiple infections. And that's what I really want to draw your attention to is actually there are more people who are reporting long COVID now after they're getting cumulative infections. So it's not a question of having an infection, not getting long COVID, thinking, right, fine, you're out the woods, never going to get long COVID again. But I also want to draw your attention to the end of the graph, and I'm going to talk about this more, though it's not highlighted, is you can see people who report being vaccinated or unvaccinated. And those who report being vaccinated have a far lower incidence of long COVID than those who are unvaccinated. This is a US study. So what causes long COVID? When we first started seeing long COVID, this was really the image that came to mind, particularly when you're seeing patients who referred to specialist services. This is the myth of the story of the blind man and the elephant. So blind men or women see an elephant and they just get a bit of it. And because they're only seeing a bit of it, they associate with what they know with that bit. And the same is true of the medical profession. So when people with long COVID first started presenting to cardiology, to gastroenterology, to neurology with complex symptoms, but had been referred for one core symptom, say brain fog or gut problems, then the gastroenterologist would say, well, I think long COVID is the gut. And there's lots of papers saying from early in the pandemic saying, well, long COVID is this or long COVID is that. And actually what we do in our clinic is really take a step back from that and try and look at the whole holistic patient with all of their symptoms and try and piece together, a bit like a jigsaw puzzle, what's going on. And when you take a step back, there are two main hypotheses or ideas about what's driving symptoms in all these different organs. One, you may have heard this idea about viral persistence. Are there bits of the virus still in our bodies that are hanging around and causing inflammation? Or has the virus trained our immune systems to start attacking itself? And that's why we're getting multi-system symptoms. When we narrow that down a little bit more, what do we actually have evidence for? Well, I'm going to talk a bit more about antigen persistence and about autoimmunity. But at the core, it's clear that across all the studies, there's immune dysregulation. The immune system is not working properly. It's either working a bit too much or a bit too little, and it's not necessarily controlling or attacking or managing in the way that you would when you're sitting here feeling normal and well. We know that there's definitely evidence of microvascular dysfunction in people living with long COVID, and we know that there's lots of problems with the gut, and I'll talk about that in a bit more. There is this story about reactivation of other viruses, but so far, no one's actually detected those viruses. They've detected an immune imprint from those viruses that may be enriched, but there's no definitive data yet to show that those viruses are reactivated and causing disease. That may come. We'll keep an open mind. Remember William Osler. I refuse to be dogmatic about any of this. So if we take that core of immune dysregulation and inflammation that sits in the middle, when we think about autoimmunity, there are two experiments which really have shown that there may be some strong data that are emerging behind this. So these studies were done identically. I'm showing you the US one, but there was one done in Amsterdam at the same time. And they went onto a preprint server at the same time, within a week of each other. And I understand that they're both about to be published, but they haven't been published yet, but they will be. And essentially, they did the same experiment. And it's quite cool that two groups did the same experiment completely independently of each other. And what they did was they took blood from people who were living with long COVID, people who'd recovered from COVID, and blood that was in the freezer from before the pandemic. So people had never seen SARS-CoV-2. And then they took out the antibodies, the immunoglobulins, just that, and purified that, and injected them into mice, and watched what the mice did. And some of the symptoms from the long COVID patients were recapitulated in the mice. Not all, but some, suggesting that there were antibodies which are part of long COVID, which are driving symptoms because they were recapitulated in the animals. When those animals were sacrificed and looked to see where those antibodies were binding, they found that they bound to nerves, which if you suffer from long COVID probably won't surprise you. And lots of my patients, when I've talked about this study in clinic with them, have said, well, that makes sense to me. That feels like that might be what's happening in my body. This other idea about viral persistence, this is a summary study which just summarizes nicely all of the different places where people have looked for bits of virus in people living with long COVID. And there's no doubt if you take biopsies from people who are living with long COVID, you can find bits of virus. But if you take matched biopsies from matched control people who have not got long COVID, you still find bits of virus. When people die with COVID or even without COVID, and you do a biopsy up to 12 months later, you can find bits of virus. So whether virus is driving disease, we don't know. But there was one very nice study in China that was published in the Lancet Infectious Diseases last year, where they had people coming for an operation. So they needed surgery for a hip or for a gut tumor or something. And lots of them had COVID before they came for their operation. So the operation was delayed. For all those people who had COVID, at the time of the operation, they took an extra bit of tissue from the biopsy and then looked for virus in that tissue, sampled that tissue. And then what they found was that people where they found the virus in the tissue were more likely to have long COVID symptoms. So that's a bit of suggestion that, yes, maybe the virus might be involved in long COVID. It's certainly the first experiment where people really thought carefully about how do we test this properly and look in tissues. But whether it's actually driving disease, we don't know. No one's proven that yet. And no one's really proven where the reservoir is. If there is a reservoir of viral antigen, where does it live? Patients complain, as I mentioned at the beginning, of lots and lots of symptoms. When you're living with long COVID, there's lots of symptoms, but a few dominate. So I'm just going to talk now about a little bit of data underpinning two of the most common symptoms, which really reinforce the biological basis of this disease. So the first is brain fog. I'm sure you may have heard this term. Lots of us complain about it. Oh, God, after that meeting, I had a bit of brain fog. Oh, I'm not sure I need a coffee. This is different. Brain fog for living with long COVID is different. It's really debilitating. You heard Mag mention it. She gets very forgetful. She can't hold information. She struggles to interact cognitively with complex tasks. She's had to give up her job as a coder and a leader as a result. So there are a few studies now have looked at functional MRI, so scanning of people, very sophisticated research MRI, not your bog standard clinical NHS MRI, but a functional research MRI in people living with long COVID. And they found some interesting things, some patterns of inflammation within the brain, and also some leakiness in the blood-brain barrier, suggesting that the barrier that protects our brain from the blood might be a bit leaky, and inflammation, molecules that drive inflammation, may be moving across between the brain and the blood, and that would be driving brain fog, potentially. There's an association. It's not proven, but it's an association. And certainly if you test the blood of people with long COVID who suffer from bad brain fog, often you find biomarkers we would associate with a head injury in the blood, suggesting that there is brain inflammation that is driving the brain fog. There's also, we know that patients have that long COVID is associated with migraines, and bad migraines and brain fog and migraines, and we think that that's probably due to pathology in the tiny blood vessels in the brain. So the other main symptom that Ali and I were talking about just before, that lots of people with long COVID and MAG referred to, is this the corona coaster, the post-exertional malaise. You start to feel a bit better, you do something, you take your dog for a walk, you go to the shops, you do something, and then you collapse, as Mag has said, in a mess of pain and exhaustion. And you have what's called a crash, and you have to recover from that. What's the biological basis of that? We started to observe this in our clinic a long time ago, back in 2020, when we started doing exercise tests for our patients in clinic, and we literally just walked them up and down the corridor, nothing else. And we saw changes in their blood that we would see in people who run a marathon just walking up and down the corridor. They had switched into what we call lactic acidosis, which is where your cells aren't getting enough oxygen. They start to work in a slightly different way. They chuck out lactic acid. It's what gives you a stitch. If you really run hard, lactate gives you too much lactate in your blood gives you a stitch. But these were people who were just walking up and down the corridor. So then we started to say, well, why is this? Because crucially, the levels of oxygen in the blood were normal. These people were not hypoxic, but they had a lactic acidosis. What was driving that? So we teamed up with a very clever hematologist called Marie Scully, who was the woman who described the mechanism by which the AstraZeneca vaccine causes clots. She's a very clever and brilliant woman. And so we started to look at this and understand that actually there was evidence that people had inflammation in the lining of the small blood vessels, and that when they exercised meant that not enough oxygen went into the muscle. And that was probably what was driving the lactic acidosis. This was backed up in a lot more detail by colleagues from Amsterdam who did a very elegant study where they took 25 people with long COVID and they did muscle biopsies before and a day after exercise challenge. And they did identical with matched controls. So people who recovered from COVID who were otherwise fit and well. And what they found is the long COVID patients, up to 40% of them had muscle necrosis, dead muscle on biopsy after exercise. So they actually had induced the killing of their muscle. And not only that, that they had found that immune cells had swept in to try and clean up the mess. And so when patients say, well, I crashed, I explain, well, this is what's happening. Not only has your muscle, some of your muscle actually died, but your body is actively trying to repair that. And that is incredibly fatiguing. Your body is literally telling you to lie down, not use that muscle while it repairs it. And one of the problems with long COVID is that we have to live. We have to move. We have to take our children to school. We have to get to the shops. The dog needs walking. It's very hard to just not move and recover, and that can be that's why it's such an incredibly debilitating symptom. So I'm going to switch tack now slightly and ask the question, is long COVID preventable? Could we have prevented all of this? Well, this is a large, huge study looking at over 1 million participants in vaccine trials across the whole of Europe from 2020 to 2021. It's a complicated figure. I'm sorry about that, but essentially what I want to draw it's a block of 4 different main studies, all split into different vaccine cohorts. And that dotted line you see is what we call the hazard ratio of 1. And so if having a vaccine moved you into more likely getting long COVID, then in each cohort, the dot with the lines would move to the right. And that if having a vaccine reduces your incidence of long COVID, moves to the left. And in each of the cohorts, the red is the summary of the 3 cohorts before. And what I hope you can appreciate, particularly from the first set of blocks, is in all the studies, in all of the cohorts, having a vaccine reduced up to half your risk of getting long COVID. And it didn't matter. The other 2 blocks look at Pfizer versus the Chaddox vaccine. It didn't actually matter which vaccine it was. Being vaccinated had a protective effect against getting long COVID. What about if we treated acute COVID infections with antivirals? Would that work? Well, one of the caveats of this is that all the antivirals were restricted to people who were considered at risk of hospitalization and death. So it's not you could go to Boots and say, oh, please, can I have some Paxlovid? You had to meet very strict criteria, and it was hard to get. But in this study in the US of 3 million people, it's an observational study, not a clinical trial, the overall risk in that 3 million people of getting any post-COVID or long COVID condition was 2.7%. And that was reduced, not hugely, but it was reduced by the administration of people who got Paxlovid. But it's observational, it's not a trial, it's whoever managed to get hold of the drug. In the UK, there was a trial, Panoramic, which tested a different antiviral called molnupiravir. Some of you may have been in that trial. My husband was. And these were clinically at-risk adults, and they were randomized 1-to-1 to get molnupiravir or not. When they went back to look, the trial was powered to reduce hospitalizations and deaths. It was not powered for long COVID. But when they did go back and look at long COVID, they did see a risk reduction of persistent symptoms, but only 2.5%, so it's small. And when they calculated what we call the number needed to treat, how many people you need to give molnupiravir to reduce one case of long COVID, it's 600. So not worth the money, essentially, to prevent one case of long COVID. It's not a good enough approach. What about this? Metformin is unusual as a diabetes drug. So this was a trial in the US which was looking at repurposed medicines, again to treat acute COVID and reduce inflammation and reduce hospitalization and death. This is something called a Kaplan-Meier curve. When I'm teaching students about these, I always say, what I want you to do is work out where you personally want to be on this graph. Which color? Do you want to be red or blue? On the y-axis, the long bit on the side, we're looking up at percentage of people who got long COVID at 300 days in the study. And so we're looking at time on the x-axis going along. So do you want to be red or blue? Everyone says blue, right? But the caveat to this is that actually when you dig down into the effect in that trial, who really benefited from the metformin, what was driving that reduction in long COVID, it was people who were living with obesity, particularly morbid obesity, who hadn't got a diagnosis of type 2 diabetes, but clearly did benefit from having a diabetes drug. So not necessarily applicable to everybody, but a really interesting finding that actually modifying metabolically people with acute COVID reduce their risk of getting long COVID. That's a very intriguing thing. So moving on, can we treat long COVID itself? So again, people thought, well, if there's a viral reservoir, then can we treat that with Paxlovid? It's the most available antiviral drug that we have. There are currently 6 trials, 2 of which are completed, 1 which is published. So far, there's no data to support Paxlovid as a treatment for long COVID. But again, the jury's really out because we've only got 1 trial so far. It's really important to do these trials, and every single study that we do, we learn from. So although patients are very disappointed when a trial reports a negative result, the drug did not impact on their long COVID, we learn something each time and we get better. And every time we learn, it's an iterative process. It's never a one shot, that's it. So what about vaccination? Well, this is an observational study that looked at people who had a vaccine or not. And this is obviously choice, accessibility, lots of things, lots of biases in here, who had a vaccine or not after the onset of long COVID. And then what happened to their symptoms. And people who, in this study, who got the vaccine after the onset of long COVID, they recovered faster, essentially, than people who didn't get a dose of vaccine after the onset of long COVID, suggesting, but not proving, that vaccine and that stimulating the immune system with a vaccine may modulate the inflammation that's going on with long COVID. But this remains to be tested in a formal, proper trial. Other trials that are reported recently are plasma exchange. This idea, go back to that autoimmunity hypothesis, if actually you take out all those antibodies and replace them with someone else's, which is what plasma exchange is. It's pretty hectic. The first trial to do that has reported no efficacy. There's another trial ongoing in Amsterdam at the moment, that same team that did the exercise study. But it's a pretty hectic trial to do because you've got to put a dirty, great line in someone's neck. You've got to take half their blood volume out, clean it, and put it back in again. It's not a straightforward or low-risk thing to do. And I can see some faces being pulled in the audience. They're thinking, I don't fancy that. Thank you very much. Donezepil is a drug for dementia. and it was thought that that might help modulate brain inflammation and brain fog. No efficacy. But I have to tell you, these studies are small and they're very select patient groups. They're not applicable large-scale studies, but they're often what we call proof of principle. And if you have a proof of principle and you start to prove an idea, then you can apply for money to go on to do the much bigger trial. Here's another study, AXA 1125. This was a phase 2 study done in England, looking at modifying metabolic activity within cells. This study failed to meet its primary endpoint. It did, interestingly, in the secondary endpoint, show that the intervention reduced fatigue, but the study was not powered for that. It was a secondary, not a primary endpoint, and that meant as a drug didn't meet the primary endpoint in this phase 2 study, it was not able to progress to phase 3, and that company has now gone into administration, so that drug is not going to progress. This is an interesting idea. So this is a probiotic that's synthesized and made for the Chinese gut. And this is a really nice study that was done in China in people living with long COVID. And it was really well randomized and blinded and powered. So it was a good quality study. And they showed that people who got the blinded microbiome, so these are basically bacteria probiotics that are enriched for the Chinese gut, it reduced fatigue in long COVID. So an intriguing idea that actually maybe gut modification may be a useful way of maybe thinking about the pathology of long COVID and treating long COVID, but again, not fully proven. And as I say, this was designed specifically for the Chinese gut. So active drug trials at the moment, the NIH funded $1.15 billion of long COVID research a couple of years ago called the NIH Recover program, and most of these trials are being funded by Recover. So these are drugs that are currently in clinical trials for disease modification. There's a whole range of antivirals, some targeting SARS-CoV-2, some targeting other viruses. There's a range of anti-inflammatories, including metformin, in its anti-inflammatory rather than its diabetic capacity. Steroids, asthma drugs. There are drugs designed to modulate your immune system. Specific antibodies targeting cytokines. Tocilizumab was in the recovery trial. We use it to treat severe COVID. It targets a cytokine called IL-6. And then there's a bunch of others of investigational medical products, so we don't know what they actually are. And there's also more trials of probiotics, autologous stem cells, and fluvoxamine, which is actually an antidepressant with antiviral activity. And then there's another bunch of trials which are going on at the moment, all looking at drugs that are aimed at symptom control rather than disease modification. And you can find all of these on this website, clinicaltrial.gov. So what does all of this research tell us? I want to step back a bit. I've given you a lot of data. Hopefully I've shown you that long COVID is an inflammatory disease that's underpinned by microvascular dysfunction. It can be prevented. It is potentially treatable, but we need better scientific approaches and not old assumptions. No dogma has to go. But what we really want to know is what's the right drug target out of all of this? What can we do? So this takes me on to part 2. What are we doing about long COVID? So here's William Osler again. This was a founding principle with which we set up the long COVID clinic. If you listen to patients carefully enough, they will tell you the diagnosis. And I have sat for 5 years in the UCLH long COVID clinic with my colleagues, listening to patients. And what I really listen to their symptoms, the impact on their lives. And what's really remarkable is how similar, while there's a huge range of symptoms, the core set of symptoms and the core life impact of long COVID is remarkably similar. The UCLH Long COVID Clinic is an unusual and remarkable place. It was started by my heroine, Melissa Heitman, in the back of a van in May 2020. And this is because she's a lung doctor, and her job is looking at lung fibrosis. And she had read about SARS-CoV-1, where lots of people did get lung fibrosis after infection. She wanted to be at the forefront of understanding if people would get the same. This is a van that was previously used by the homeless team to drive around London and look for TB in people who are living on the street. She co-opted this van and drove it around, finding people with long COVID and x-raying them at home. Really extraordinary mobile clinic that rapidly transitioned to a much broader UCLH long COVID clinic, of which I'm extremely proud to be part of. I work with a totally brilliant multidisciplinary team of physios, OTs, nurses, administrators, specialists, and we also have a broader, strong collaboration with cardiology and neurology particularly. Melissa became the long COVID lead nationally for long COVID services, sits at round tables in Whitehall and argues the case for patients and for money and for research and keeps clinic going. And through her efforts, we have this network of long COVID clinics nationally. We've supported 15 research studies so far through the clinic, and we wrote the NICE guidelines in 2022, which definitely need updating, but none of us have got time to do it at the moment. We have a multidisciplinary, multi-specialty meeting once a week to discuss complex patients, and that's very unusual in the NHS. So instead of saying to my patient, well, I think you should see my neurology friend, and you're going to have to wait 6 months to see them, maybe a year, I say, well, actually, let me bring you to the meeting. I'll discuss your case, and I will get an opinion from neurology, cardiology, psychology, primary care, respiratory medicine, infectious diseases, as physiotherapy, all in one go. It's really extraordinary. So we can really accelerate people's care, and it's a model for how the NHS really should operate rather than passing people around between specialties. We also do a lot of work with charities and advocacy for patients and services. And this is some of our online videos. If you go to the clinic website, you can watch some of the videos that our team have made that go up there that support our patients. We run a prize from the Royal College of Physicians for a extraordinary response in a time of emergency. And if you want to understand a bit more about the clinic, I recommend you listening to this on the BBC Inside Health. They came to the clinic and they interviewed some of our patients. They interviewed us to understand a bit more about what we do, and it's worth a listen. So back in 2020, myself and my colleague Toby Hillman, who's a respiratory specialist, were sitting there and we were like, these patients, like, how can we understand this better? And I was like, we really don't know. This is a new disease. We have to do a trial. So we decided that we had to do the trial. He agreed with me, fortunately. He and I are still friends. And what do you do when you want to do a trial in a new disease? Well, the first thing you need are some friends and colleagues. So we're incredibly fortunate already to work with Mel Heitman, and we also started to work with Ami Banerjee, who is a cardiologist and a professor of data science, and was putting together a grant application for a broader piece around long COVID. And we brought together essentially a small team, and we had to make some decisions very quickly. What was our research question? What was our primary aim? And what was that intervention? And this is where the patients come up. Expert patients are so important because we're sitting there beard stroking away, but actually we need the patients to help us inform. If it's a patient-defined disease, what do the patients want to know? What's the crucial question? Then you have to build a network. You need patient experts, you need trial experts, and you need a network of collaborators. And then you have to spend your summer holidays while you're on trying to climb a mountain with your children, writing a grant, designing a trial, finding the funding. And then once you've done all of that, £6.8 million, we're in the pub going, yay, we've got the money. A year later, we start the trial because of all the regulatory hurdles. So it took time to get going, and that was a real shame it took so long to get going, but it did. We've now closed that trial. Whew. And then you have to open all your trial sites. And the key to the powerful research in long COVID is the patients, keeping the patients at the center of what you do. Mag and her team have been absolutely crucial. They come to our meetings, they give us advice, they ask questions, and they support, and they say, well, actually, what about this? And I was talking about a study with them recently, and they said, but what about the people who can't make it to clinic? How are you going to build those into your design? And I really rethought my design and thought about actually how can we do that and reach out to those patients better. So when we set up Stimulate ICP, our trial, we first wanted to understand what the pathway looks like. This is a conventional pathway for patients. You go to your GP in primary care. If you're lucky, you get a referral. Lots of patients didn't get a referral, had to go back 3, 4, 5, 6, 7 times to get their referral. And often they get some basic tests done. And GPs will often say, well, let's just find another reason why you're tired. Are you anemic? Is it your thyroid? Pretty standard stuff. And then you might get some other tests, and then you come on to the long COVID clinic. We talk to you and we do an assessment, and then we set up a plan to help support you in the community to help you recover. That was what was happening, but it's very patchy, and nationally we didn't really understand. So part of the trial is work package 1, what's going on in the existing long COVID clinics. And then work package 2 is this complicated trial design where we ask the question first, can we do extra tests, a special MRI scan before you come to clinic? Does that help? Can we offer you a drug at clinic and randomize you to one of 3 drugs or usual care? And then can we enhance your recovery? So this is a huge trial and complicated to design, complicated to unpick statistically. And then we also asked the question, actually, we're sitting here in London designing this in our nice UCLH clinic, but actually, what about inequalities? What about the people who can't get to the clinic? What about people who may not have as much of a voice? So we had work package 3, which was to understand the impact of structural health inequalities on long COVID. So what am I doing in all of that? Well, I helped design the drug trial, and I've been leading that bit, but I advocated from the beginning that what we really need to be doing is something called reverse translation. So translation is where we, in sort of medical scientific terms, is where we spend some time in the lab understanding a disease. We think, right, we should treat it with drug X, and then we translate forward into the patients to treat with drug X, and we test that. Reverse translation, particularly in new diseases, we can't just go in the middle and say, right, well, let's study this. We don't know what we're studying. It's a new disease. So what we did instead was say, well, we're doing this trial. We're doing this experiment. Can we look from the clinical studies and reverse translate that by biological enrichment? If we give people drug X or drug Y, and people get better with drug Y but not drug X, what does that tell us? Can we dig down into the samples from those patients to try and understand what drove that difference and what insight is that going to give us in long COVID? And that work's ongoing. Then we can say, right, let's get some hypotheses going. What we think is going on in long COVID, can we test that in the lab? And then can we go back round that forward translation loop and bring that forward back to the next trial? But we need to do this faster, because this is a horrible disease affecting lots of people who are desperate for drug treatments at work. So we link in correlation with real-world data from the clinic and from the trial, and that helps us accelerate the target design when we can subset people by what we call endotypes or groups or symptom clusters. And then in the heart of it, we embed the patient lived experience. What's changing? What are the priorities? What are patients experiencing? What do they really want to know? So why me? Why can I do this? Or why can I work within the Crick? Well, I told you at the beginning that I was already here doing a fellowship. But when I came back from that stint in acute medicine, I was offered a new job, which was leading the UCLH-Crick partnership on COVID. And this was really an extraordinary endeavour that had already been set up and was running between the Crick and UCLH, linked up with the Health Services Laboratory. And this was essentially to provide testing, PCR testing for SARS-CoV-2 for healthcare workers across northwest London. And the idea was that actually if you can test regularly and you test positive, even if you're asymptomatic, you step out of the workforce, and therefore you're not going to infect your colleagues and your patients. And so we published data from this pipeline. It was extraordinarily effective. And it was led by a team of brilliant scientists and colleagues and collaborators, some of whom have become close friends here at the Crick. Over 2 years, the pipeline ran 680,000 PCR tests for 12 NHS hospitals, 98 local care homes, 1 mental health trust, and 4 research institutes. And we published some of the data, as I said. You can have a read about the impact of that. But we sent the data to the COVID inquiry and to the House of Commons, who were having a specific inquiry about pandemic preparedness, because what's clear from our data is that you need to set up testing fast. We were operational in April 2020. It took a month for the Crick, this amazing building, to set up this testing pipeline. But also, we were providing a service where there wasn't one. And what we found is when we look back at the data that we were detecting new variants up to a month before they were declared a variant of concern in healthcare workers. And those healthcare workers were removing themselves from the workforce. So actually we were stopping the spread of new variants in hospitals without even knowing it, and emphasize how important testing is. So out of that was, well, how can we use the legacy of the testing pipeline? Well, this is the legacy study that I lead between here and the Crick and UCLH, with a bunch of incredibly talented colleagues who've also become good friends, David Bauer, Mary Wu, and Ed Carr. And this is a prospective observational cohort study of people who were using the testing pipeline, who very kindly given us consent to call them up, email them regularly, ask them to come in for visits, take their blood, and study the immune response to the vaccines and to subsequent infections over the last 5 years. So we've got an incredibly rich resource from people who are otherwise healthy, some of whom less healthy, but mostly healthy adults, and how people respond to different viruses and different vaccines. Why is this important? Well, this provides the perfect set of control participants for looking at our reverse translation stimulate ICP. Because what's really important is when you're looking at a control population, you want to know how well matched are they to your people with long COVID? Because if they're very different, if they've had different vaccines or they've had different infections, their immune response might be different and therefore they're not a good comparator. So Dave Greenwood, who's a very talented bioinformatician, biostatistician in our team, he has been pulling all the data from STIM and all of the data from Legacy and matching up really carefully so we can match up by age, by gender, by days since infection, and by vaccine type. And what became very apparent is actually lots of our long COVID patients are unvaccinated, so that makes it a bit harder to match because our Legacy cohort is almost entirely vaccinated. But we're now very aware of that bias and we can now take steps to control it. And what he's essentially been working on is integrating all the data from the clinic and the trials, the lab data, the symptoms, with the data we generate from platforms here at the Crick, and doing the same for Legacy and for Stimulate, and then being able to really generate really powerful comparisons because we've got big numbers. We've been working with one of the scientific technology platforms here at the Crick proteomics platform and a very talented scientist, Christelle, who's built a high throughput platform for looking at proteins in people's blood. And there are lots of different ways of doing this, and there are various commercial platforms that are extremely expensive, but they're also quite biased, lots of them, because you have to pick, do I want to spend £250,000 on 380 proteins in my 500 samples, or do I want to do 2,000 proteins? But those arrays of proteins have been chosen by other people, usually for other diseases, certainly not for long COVID. The approach we've taken is, remember that William Osler and his dogmatism, we want to remain unbiased, we are agnostic, we want to keep our minds open. So we ran all the proteins and saw what we could hit. And the data are currently beneing analysed, and Christelle's been extraordinarily helpful with this. And then finally, Gift is another talented scientist within our team. She's trying to answer the question, well, what about the T cells? This is a recurring question that we get a lot. And she's built up a beautiful set of tools for really understanding T cells in detail, both looking at the populations of the cells that people with long COVID have in their blood when we compare to our controls, but also what happens if we prod them with a bit of spike. Does that change the number of the cells, or does that change how they behave? And actually, she's got some lovely data which is being put forward to publication. This is not people with long COVID, this is just Legacy, but really elegantly profiling out all the different subsets and how they behave. So going back to our reverse translation loop now, we're moving around it. So Stimulate has finished, it's closed. We've done our 6-month follow-up in January this year. Results expected later this year, watch this space. The lab work is ongoing, and then we're starting to design the in vitro experiments for the lab work. And then finally, we're looking to push forward translation, and I've already had a meeting with translation team at the Crick to understand how we can best push forward translation from these data. And then the plan essentially is to move forward to STIM Part 2. What's the next trial with a more accurate drug target than Toby and I doing some beard stroking back in 2021. So finally, Part 3. What does the future hold for long COVID? Well, there's a lot of UK investment in cohorts in 2020 and 2021, which is now paying dividends. The FOSP COVID collaboration was looking at people who've been in hospital and long-term follow-up, and they've provided extraordinarily rich data, and we're starting to work more closely with them. They're already taking their data forward into clinical trials. The SIREN study is a healthcare worker study of 20,000 people that's ongoing, and we're working with them to do a sub-study of long COVID within SIREN participants. Stimulate is finished, as I said. Convalescence was another study at UCL that was an epidemiological study of long COVID, and we're now starting to understand a lot more about UK epidemiology. There's also some studies that have been going on in people living with immunocompromise. Octave Dewar, Stravinsky, and Consensus is specifically targeted at older adults, so people who are 70 years and older. Trial data that's due in the next 25, 26, well, STIM, hopefully this year. The NIH Recover trials, they're all going to keep reporting out. And there's a study getting started in the Netherlands called Reclaim that's recruiting very fast, and that may even report out next year. And this $1.15 billion of investment in the US for lots of these trials hopefully will really start to pay off. But there is an orange elephant in the room, and all COVID research in the NIH got cancelled earlier this year. Literally, Control-Alt-Delete, grants that had the word COVID in got cancelled. But this is a real remarkable story, I think, because every scientist in America who's had their research cancelled by the NIH by this activity is furious about it, but they're not able to get that money reinstated. They're going to lawyers, they're going various different mechanisms. The patients got the long COVID money reinstated. Their advocacy, online and in person, worked so that decision was reversed for NIH, for the Recover program. So the long COVID research is continuing. So big up for patient advocacy. Long COVID is a patient-defined disease, and the push forward for ongoing science continues to come from the patients. So to wrap up, what available resources while we're waiting for all these trials to come out? There are lots of charities who are there supporting. Particularly, I would like to give a shout out to Long COVID Kids. It's an extraordinary charity. If you have young people or children living with long COVID, they're incredibly supportive. There's lots of new resources that have come out of Stimulate ICP, including this website, Long COVID Care. And one of the tools it gives is useful ways to have conversations if you're living with long COVID with friends and family and colleagues at work who may not understand what you're going through. So I'm going to end with thanks to lots and lots and lots and lots and lots and lots and lots of people, most of whose names or pictures are up here, but really extraordinary thanks to the clinic team at UCLH, who are a remarkable bunch of people who it's an enormous privilege and a pleasure to work with, and my colleagues here at the Crick, both within my immediate team running Legacy and STIM, the leadership of the Legacy study who set up the testing pipeline, Charlie Swanton, Steve Gamblin, Brian Williams and Sonia Gandhi, the team at the Trials Unit in Lancashire who runs Stimulate for us, and all of the teams here in human sample management, proteomics, human biology and bioinformatics. Is literally, if anyone stands up, you ever see a scientist stand up and said, I did this, they're talking rubbish. Science is a we, it's a team. You can't do it without people, and you certainly can't do clinical translational study without brilliant people in the hospital and brilliant scientists in the institute. Thank you.